Professor Layanai.
JK, please.
Yeah, good afternoon, and this is number one. See, this is the beginning and end of the creation. So the beginning of end of the cataract surgery is incision. That's the first step and the last step. So my advice is no touch technique. Don't touch. The patient will get it. You put some forceps or bud, they get confused. So don't need. You just need two instruments, as I shown you in the video. You just do it with the two, just support with the side port and make with the main port. This we are practicing, all the surgeons in our hospital doing it. It's very easy. It's a very easy technique. Then in the end, the incision should be good enough to comfortably go for the whatever lens you are using, whatever cartridge. Don't put side instruments since spatula. I saw one video where they're putting even forceps inside the side port. No, this is ridiculous. Just don't touch. You have to just cartridge should go comfortably and go. That's the about the second hack is when you're doing all we are taught is horizontal phaco. That is taught 10, 20 years back. 20 years is a long time. You don't need a horizontal phaco. You have to do you don't need a vertical trench. You need a horizontal trench in phaco. If it's a heart, you just don't go beyond the center of the nucleus. Just do a horizontal trench, then hold it and chop it. That is my two hack. This one which is very, very, very useful to crack the even hardest nucleus. The third one is cortex. So everything goes when most of the PC rents happens in the cortex. That's what I got statistical analysis where the PC rent happens. So just before the handpiece changes, it takes 20 seconds, 15 to 20 seconds depending upon the staff nurse. During that time, do a second hydrodissection of the central cortex, and just one sweep, you can just remove all the cortex. Okay, you don't need anything else. And the fourth one is the trailing haptic caught in the cartridge. Just take your McPherson, pull it off. It will come. Don't do that. I saw in ECRS, they messed it up. That's why I'm showing this. In ECRS, I saw they are doing so many tricks. They have shown nothing works. Just pull it off in hydrophilic. And the same thing. It's a very repeatable technique. You got the trailing haptic caught in the cartridge. Take a forceps and just pull it off. That will come. Okay. The fifth one is the antibiotic prophylaxis intracameral. That's a bit still. I am using it, but not the world. Mixing in the BSS 0.1 ml of amikacin, 500 ml of BSS. That is 12.5 milligrams. That solves all the problem. That's much better. Moxifloxacin use reduces the endophthalmitis rate by 1:5. But we in our 2 lakh cases, we found that amikacin add in the BSS prevents almost 15 times. The endophthalmitis rates comes down 15 times. Thank you very much for your patient listening.
Sir, this is regarding the first video. You have shown paracentesis knife in your left hand and main incision knife, keratome in your right hand. Suppose it is the right eye, suddenly patient is getting a Bell's movement. How you tackle?
See, the complications, when any surgery will happen, complications known to happen. So I had, in my entire 15 years I am practicing this, I had 2 times this complication. So I changed the incision became too big, then I took another site and did it. It's happened. It's rare, very rare, don't worry.
MVR, nowadays I am using MVR. So MVR, once it goes in, the blunt tip remains in the paracentesis.
I never used MVR, so I know experience.
I'm just telling, as I was also using the 15 blade only. Now, because the MVR is being, the sharp end goes into the AC, and the blunt one remains inside the paracentesis, and even if patient moves, nothing happens to the paracentesis.
Yeah, the same version is available with the Oralab side ports, which are also very cheap, not as costly as the MVR. So basically, the initial triangular portion edges are sharp and cutting, but the rest of the shaft is blunt on both sides. So even if there is bells, there is no extension of the wound.
Ultimately my point is correct.
And regarding amikacin,
don't touch the eye.
This has been published.
Huh?
The results of amikacin and BSS has been published.
Published
and,
many times, many times, many times. This is very, 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 very powerful and very effective. No problem.
Thank you, Dr.